Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. I'm Dr. Jumana Karasne, and I will be teaching you some of the lectures in this course, the oral medicine course. And this is the first lecture of my lecture series. I'll be talking about oral ulceration. So the objectives of this lecture is to know what is the meaning of an ulcer, what are the possible causes of ulcers in the oral cavity, and I will introduce you to a very common condition known as recurrent after stomatitis, and no other lesions that can be clinically presented as recurrent after stomatitis or RAS. How can we tell the difference? How can we manage these conditions, particularly RAS? And we'll talk about other conditions, mainly Behçet's disease, as it is common in our region or our part of the world. So starting with the definition of an oral ulcer or of an ulcer. Okay. Oral ulcer means there is a loss of epithelium. There is a complete loss of epithelium, as you can see here. So this is the epithelial layer, and you can see that now the epithelium is lost in this area, and there is inflamed connective tissue, exposed inflamed connective tissue. Clinically, this would be seen as yellowish area, which represents the exposed connective tissue and the fibrin on the surface of the lesion. So it is very important to tell the difference. I mean, and the normal color of the mucosa is pink. When it is scratched, there is erosions. So erosions are less severe than ulcers. In the erosion, there is partial loss of the epithelium, and there is an inflammation. So this is why it appears red in color. While in ulcer, there is a complete loss of the epithelium, and this is why it looks yellowish in color. So when you start defining your lesion, the first thing is to determine the type of the lesion, whether it is an ulcer, it is a plaque lesion, it is a macule. So when you see this appearance, a yellowish exposed connective tissue with erythematous area, erythematous margin, of course, because there is loss of the epithelium, there would be an inflammation in the area, so redness is expected. So then it is correct to say that this is an ulcer. So now we know what is an ulcer. Now, what causes the ulcer in the oral cavity? There are different reasons for ulcerations in the oral cavity. The most common cause is trauma. And you just bite your cheek while chewing or bite your tongue. Maybe you can injure your mucosa with, while drinking hot tea. So you will burn the surface epithelium and it will slough and leaving an exposed connective tissue. So this is another form of trauma. So trauma is the main, or is let's say the most common cause of ulcers in the oral cavity. Other reasons include microbial infection, like viral infection, for example. Mainly viral. Bacterial, it could be like encephalitic ulcers. So you will have these in more details in the coming lectures. I would be covering more of topics like mainly RAS, which is idiopathic cause of aphthous ulcerations. The rest of the causes of the oral ulcers would be covered in other lectures. So in the microbial infections, I think you're going to have lectures on viral infections and on bacterial infections, and you will appreciate the presence of ulcers in such lesions. The third cause that I will talk in more details in this lecture is the idiopathic, where the reason is unknown. And the best example is recurrent after stomatitis or RAS. The fourth cause is a mucocutaneous disease, where these ulcers are part of a generalized condition that is affecting all the mucosal surfaces and the skin. Different examples of autoimmune conditions or immune-mediated conditions that affect the skin and the mucosa, including, for example, lichen planus, pemphigus vulgaris, mucous membrane pemphigoid. These lesions affect the mucocutaneous system. The mucosa and the skin, they are not restricted to the oral cavity, but usually the oral cavity is the first site of development of the lesion, and this is why it is important to recognize these ulcers so that you can refer the patient early to the dermatologist and manage the patient as soon as possible, which will improve the prognosis of the disease. So mucocutaneous diseases are another cause of the presence of oral ulcerations. This topic will also be covered in different lectures. Systemic disorders, so the oral ulcerations might be a presentation of other systemic conditions, like for example GI diseases, might be presented as the oral cavity, might be presented as ulcers in the oral cavity, and this is, it does make sense because the oral cavity is part of the GI systems. So when the condition or when the disease is affecting the GI, it will affect the oral cavity as being part of the GI system. Other systemic disorders like, for example, Behçet's disease is a multi-system disease that affect the joints, affect actually everything, all because it is a vasculitis, so it affects all parts of the body. So it is, or it might be presented as ulcers, very similar to recurrent after stomatitis. So these are just a few examples of systemic conditions that might be presented as oral ulcers. Drug therapies, some medications might induce ulceration, including the most common medication we use, which is ibuprofen. For some patients, it might induce ulcerations. Squamous cell carcinoma, we are thinking of that when we have a single persistent ulcer. So these are possible causes of ulcerations in the oral cavity, and as you can see, there is a long list. So it is actually important to make a diagnosis, to know what is the underlying cause of this ulcer, so you would know whether to refer the patient to treat this ulcer, how you are going to manage it. This depends on the correct diagnosis. So in this lecture, I will try to help you how to think of diagnosing an oral ulcer. The three key elements needed to make a diagnosis of an ulcer is proper history, examination, and special investigation. So in the history, you need to know what to ask. What are the questions that you should ask the patient about to make a diagnosis? The first question is about the recurrence of this ulcer. Like, is it the first time you had this ulcer? Have you ever had it before? And if it is recurrent, how often does it recur? Is the recurrence associated with certain changes in your body? Like, for example, is associated with eating certain types of food, or maybe during special time of the period cycle, like before the period or during the period for the females. So you want to determine whether this is a persistent ulcer. Is it the first time the patient had this ulcer, or is it recurrent? You want to know when the patient starts developing these lesions. Some lesions tend to start early in age, like for example recurrent after stomatitis. Usually the patient develop these lesions when they are, during childhood, like 10 years old, 7 years old, while other lesions usually they tend to start during the middle age, for example 30s or 40s, as in Behçet's disease. Other ulcers would start later in life, like in the 60s or 50s, and this includes lichen planus or immune vesiculobullous diseases like pemphigus or mucous membrane pemphigoid. So it is important to know when or at what age does these ulcers started to appear. This would help you to make the diagnosis. The distribution of the ulcers, where do they occur? Do they occur anywhere in the oral cavity? Does this include keratinized and non-keratinized area? Does it occur more frequently in the fixed mucosa, which is attached to mucosa, or movable mucosa like the buccal mucosa, the tongue, the floor of the mouth? And the importance of this question, it also helps you in making the diagnosis. For example, aphthous ulcer usually almost always occur in a movable mucosa. So we can see an aphthous ulcer in the cheek, in the buccal mucosa. We can see it in the tongue, which is the worst site, it's the most painful. We can see it in the floor of the mouth, in the soft palate, but we do not actually see it in the hard palate or in the gingiva. So when you see an ulcer in the gingiva, this should lead you to think about other causes of ulcerations other than RAS. And I would go for viral infections. For example, intraoral herpes, usually it prefers the hard palate and the gingiva. So attached keratinized mucosa is a favorable site for a viral infection. So knowing or observing or asking the patient about the distribution or the sites where the ulcers occur would help you to make a diagnosis. Family history is also important. Some cases, they have sort of genetic component, more genetic involvement in the condition. And example of that is RAS. So like if the parent is having RAS or is a patient of RAS, there's a 90% chance that one of his children would be affected with RAS. So family history is an important part in RAS diagnosis, also in Behçet's disease, while in other conditions it might not have that influence. So it is also a good idea to ask about the family history. Is there any of your brothers or anyone of the family have the same condition or similar condition? So this would give you a clue. The shape of the ulcer, the number of the ulcers, whether they are single or multiple. So when we are talking about multiple ulcerations, we are talking more of either RAS, if it is recurrent, or talking about mucocutaneous conditions or systemic condition when they are multiple ulcers. When we have only one single ulcer, usually we are thinking of a local factor like trauma or maybe squamous cell carcinoma. So the number of ulcers is important also for making a diagnosis, and the shape. Some ulcers or some, let's say, conditions tend to develop particular shape, and the main one is RAS. RAS usually have a very uniform circular shape of the ulcer, while other ulcers in lichen planus, for example, or vesiculobullous diseases, they tend to spread and be irregular, big in size and irregular shape ulcer. And if there's any associated systemic or oral signs or symptoms, and this is again very important question, because you want to know whether the ulcers that are present in the patient's mouth are a single entity or they are part of a general systemic condition. So it is important always to ask for a patient who is having an ulcer in the mouth, like, do you have ulcers anywhere else in your body? So this is a very important question. Do you have any skin lesions? So you want to figure out whether this is part of a mucocutaneous condition or not. Do you have fever or malaise or any symptoms associated with the eruptions of the ulcers? So again, this indicates or suggests the presence of infectious agents or maybe systemic condition. If the condition is just localized to the oral cavity, there is no associated symptoms, no fever, no malaise, nothing, other signs or other symptoms, so you would think or focus more on local oral condition rather than being part of a systemic disease. So all of these questions are really key questions to make a diagnosis of an oral ulcer. These are the questions, or these are the things that you must ask your patient to get to the right diagnosis. This is the first part, which is the history. The second part, going into examination. So now what are the things that you need to look at when you are examining your patient? The first thing, you need to check whether the patient is feverish or doesn't look well, or feel if he has any fever. So this is one thing that you need to check. Again, you want to check if there is any lesions, skin lesions. You might do examination of the skin lesions of the hands, nails. Check if there is any skin lesions related or might be associated with the oral ulcers, presence of scarring, so this would determine the severity, the intensity, and the diagnosis of the ulcers. Some ulcers tend to heal with scarring, like for example major aphthous ulcer, they heal with scarring. Others are just superficial, so there is no scarring. So presence of scarring in the tongue, in the oral cavity, would give you a clue regarding the diagnosis. Other intraoral changes, presence of vesicles indicates maybe vesiculobullous condition or indicates a viral infection. It starts as vesicles. Presence of striations is more suggestive. Striations, which are the white striae or lines surrounding the ulcers, is more suggestive of a lichen planus. So you need to be vigilant of these changes, which will help you to make the diagnosis. Again, the size of the ulcer, and the presence of lymphadenopathy, which is usually expected, in all types of ulcer, whether it is viral or whether it is idiopathic. As long as there is an ulcer, so there's an inflammation, we expect the lymph nodes to be involved. Usually taking history would guide you or lead you half the way to the diagnosis examination. Usually you are there. You'll get your diagnosis by completing your examination. Sometimes we need to do special investigation to confirm the diagnosis. So for example, sometimes in most of the cases, I tend to do CBC, ferritin, folic acid, B12, ESR, which is erythrocyte sedimentation rate. It's non-specific marker of inflammation. So I usually tend to do these to make sure that these ulcers are not related or are not a reflection of systemic hematinic deficiencies. I would do antigliadin and anti-endometrial autoantibodies if I am suspecting GI disease, like celiac disease, where the patient is developing allergy to wheat and he cannot tolerate eating bread or any of these wheat or barley or this stuff. So the patient would have antibodies against the gliadin, which is the antigen present in the wheat. So I would do this test if I am suspecting a presence of GI problems or if I am suspecting celiac disease. A biopsy is usually taken for an ulcer that is persistent or chronic ulcer. Sometimes the ulcers look very similar, so you would never know whether this is an ulcer of mucous membrane pemphigoid or whether it is an ulcerative form of lichen planus. The only way to know is to take a biopsy. If there is a persistent ulcer, there is no underlying cause, it has been there for a while, you should take a biopsy to know or to rule out the malignancy in that ulcer. So I would do special investigations in many cases to confirm my diagnosis. So this is these are the keys that you need to diagnose an oral ulcer. Assalamu alaikum wa rahmatullah. Welcome to the second part of the lecture. And in this lecture now, I'm going to talk to you in more details regarding some causes or etiologies, let's say, of oral ulcers. Traumatic ulcer, as I said before, it is the most common cause of oral ulcer. Usually the patient is aware of the incident of trauma. He would tell you that I bit my cheek, I bit my tongue, I burned my palate, I was eating whatever hot stuff or pizza, for example, and I just burned the roof of my palate. So there are different forms. This mechanical, thermal, chemical. The only thing I'm thinking of in chemical is aspirin burn, where the patients used to put the aspirin tablets on the site of the painful tooth, and because it is a salicylic acid, so it would burn the mucosa, inducing an ulcer. So the patient is aware of that ulcer. You need to find the cause of the ulcer, like the mechanical cause of the ulcer. There should be a clear history of the trauma to make a diagnosis of traumatic ulcer. This is, for example, an ulcer. As you can see, there is yellowish base, and there's inflammation, and there's not just inflammation, there's actually a swelling here around the ulcer, which indicates that this ulcer has been there for a while. We call this a rolled margin. Sometimes it is even more rolled. So a rolled margin of an ulcer is an indication that it has been there for a long while or for a long time. So this ulcer has been there for a long time, and the patient actually was not sure about the cause. But when we examined the tongue while the patient is resting, we found that the site of the ulcer, it coincides with this protruding cusp of this tooth, and there's lots of calculus and plaque in that tooth that induced the irritation. So we thought probably this ulcer might be there because of this malaligned tooth, over-erupted tooth. The first step you need to confirm your diagnosis is try to remove that cause. So we made an initial diagnosis of traumatic ulcer, and our first step of management would be removing the underlying cause. So you either extract that tooth if it is like a hopeless tooth, or maybe you just do correction, grinding the cusp, for example, so that it is not interfering with the tongue movement. So you try to remove the underlying cause. If the ulcer is a big ulcer, we can prescribe chlorhexidine mouthwash just to prevent secondary infection. The main thing here, the main key here, is to review the patient after 10 days. So do not ever remove or consider that this is a traumatic ulcer, that's it, I will just extract this tooth and that's it. Because there is a possibility that this was not an ulcerative or a traumatic. This was not a traumatic ulcer. It is actually the beginning of cancer, and it happened to be there in this location, and you thought that it is a traumatic. You extracted the tooth, dismissed the patient, and that's it. The patient will come to you after like 6 months telling you that, doctor, the ulcer, I think it has got bigger. And when you see it, that's it. It's a cancer. It is in there. So whenever you make a diagnosis of traumatic ulcer, it is never enough just to remove the cause. You need to remove the cause, follow up the patient after 10 days, and see that it has improved significantly or healed completely. If not, a biopsy is a must. Other form of ulcers is factitious ulcers or self-inflicted, that the patient does this ulcer to himself. Usually patient, they deny trauma. Maybe it's a habit that he's not aware of, or maybe he's trying to seek attention or taking sick leaves or whatever. So the patient keep coming to the clinic complaining of an ulcer here or ulcer there, and he denies any trauma, or he denied picking on that site, and this will leave you confused. So whenever again, you need to follow up the patient. You need to educate the patient that it might be a habit that he's not aware of. You need to, if he's living with a family member or with a spouse, just to make sure or ask him, if you see me doing certain movement, certain stuff. Usually they tend to pick on their gums, so you see a gingival recession, you see ulceration in their gums, or maybe just biting on the cheek or on the lips. So you can see, in this case, you can help the patient to determine the cause of the lesion. Usually it is a single ulcer, and usually it is in an accessible area or accessible site to the patients, like the lips or the cheeks or the gums. So you need just to talk to the patient, and based on what you see during examination, if it is sort of a habit that he's not aware of, you might help him to stop this habit. If he's sort of his attention seeker or seeking sick leaves, etc., then you can refer the patient if there is a psychological underlying cause, or just, if he's just trying to get a sick leaves, then you dismiss your patient. Of course, this is when you are, when you confirm that the diagnosis of fictitious ulcers. The main topic for us today is the recurrent after stomatitis, or recurrent oral ulcerations. So it all refers to the same condition. This is one of the most common oral mucosal disorders. It is very common in the population. Maybe quarter of the people are having this condition. How bad it is, how severe, some patients, they have like very bad episodes of recurrent after stomatitis. Other people have less severe, that they can manage. They just have bad one day or two and that's it. Some patients have the recurrence very frequent, like 3-4 times a month. Other individuals have it like maybe once every 3-4 months. So the recurrence rate and the severity, it varies among people. As I said, it usually involves non-keratinized movable mucosa, so the site would help you to confirm the diagnosis. When it is so bad, when the patient had a very bad episode of aphthous ulcers, he would not be able to eat, to talk. Some patients, actually, when they have a prolonged episodes, they tend to lose weight because they just cannot eat. So based on the severity of the ulcer, they classified the disease into a simple aphthosis or complex aphthosis. In a simple aphthosis, usually the ulcers are sort of a mild form of an ulcer, lasts for few days and recurs very infrequently, while in a complex aphthosis, it's really a big problem for the patient. The ulcers could be major type of ulcer. They recur very frequently and they are really resistant to treatment and giving the patient very hard time. So based on the severity, we classify it into simple or complex aphthosis. Based on the shape of the ulcer or the type of the ulcer, we classify it into minor, major, or herpetiform, which we will see photos for these forms later on. So again, when you want to confirm the diagnosis of a RAS, you follow the same key: the history, the examination, and special investigation. And you'll ask about the recurrence. It is recurrent. The patient usually is young. The site affecting movable mucosa. There is positive family history in 85% of the patients. The shape, it varies, might be minor or major or herpetiform. There is no associated symptoms, no fever, no malaise, and no GI symptoms, no skin lesions, nothing. It is just localized oral ulcers present in the oral cavity. So we call this a diagnosis by exclusion. So you are actually making a diagnosis based on excluding all other possible causes, and once you ruled out everything else, then you can confirm a diagnosis of RAS. By doing the examination, these are the three forms of RAS. This is the most common form, which is a minor aphthous ulcer. Usually the ulcer is about 5 millimeter in diameter, round shape, red erythematous margin, usually multiple ulcerations, and so this is the most common form. I've seen few cases of major aphthous ulcer, and as the name implies, a major is bigger in size. It's 1 centimeter or more, and it is deep ulcer. It is extremely painful. Usually it affects the posterior part of the mouth. Here we are seeing an example in the buccal mucosa, but which it might happen there. The most common site usually is the posterior part of the mouth, like in the soft palate. This ulcer lasts for maybe a month or so. While the minor ulcer, within 7 days, that's it, it is healed. So a month, it is giving a patient a hell of time, like he cannot eat, he cannot swallow, he cannot even breathe when the ulcer is in the posterior part or in the pharyngeal, oropharyngeal area. And it heals with scarring. Usually we can see sites of scarring of the previous episodes of ulcer. And the third form is the herpetiform, is the least common form. I've just seen one case of herpetiform ulcer, which indicates how rare it is. And the patient have multiple ulcerations, very small pinpoint like ulcers. This is not a single ulcer. This is a coalescence of multiple ulcerations. They appear as one big irregular ulcer, but they are in fact maybe 5 or 6 ulcers are joined together into one. Again, it might occur anywhere in the mouth. The most common site is the floor of the mouth. I've seen it once in the floor of the mouth. And very peculiar form or let's say characteristic of this ulcer, it responds very well to a tetracycline mouthwashes. Very good results are achieved by doing the tetracycline oral rinses, which is an antibiotic. So these are the 3 forms. The patient can develop multiple forms, but this is not very common. The patient might develop major and minor forms of the aphthous ulcer. Usually if they have the herpetiform, they have just the herpetiform. But again, this is like variations. It can happen because it can be presented in any form because the underlying cause is the same, which is immune hyperactivity or immune mediated. It is sort of a complex genetic disorder, or we call it multifactorial, where there are certain genes are involved. There might be hormonal effects, there might be hypersensitivity to certain types of food. Stress is the major contributing factor. Smoking cessation is another very contributing factor, and here I'm not encouraging you to start smoking, but it has been confirmed that smoking provides protection against RAS because the possible etiologies is it increases the keratinization of the oral mucosa, so this would add more protection against microtrauma, or because of the substances present in the nicotine itself, it might reduce the inflammatory mediators. So smoking would reduce the risk of aphthous ulcer, but it will increase your risk to cancer. So it's up to you to decide which is better to have. Minor trauma. So many patients with recurrent aphthous ulcers, they report that when they go to the dentist to do, for example, scaling or just a minimal filling, they tend to have massive ulcerations all over their mouth. This doesn't mean that the dentist didn't do his job properly or traumatize the patient. He did not. But the tissues are so sensitive that with any stretching or any touching of the oral mucosa, they tend to develop an inflammation and develop the ulcer. So it is a multifactorial disease with several underlying causes that are put together to make this patient more susceptible to develop the condition. So what happens? What goes wrong? We know it is idiopathic, we know there is a genetic factor, but what goes wrong to make this patient susceptible to develop RAS? The immune system, the hyperactivity of the immune system. So we call this condition an immune-mediated disease. It is different than autoimmune. In autoimmune, there is autoantibodies produced by the immune system that attack self-antigens. So you can locate and see these antibodies. In immune-mediated, as in RAS ulcerations, there is no autoantibodies, but there is exaggerated inflammatory response. You will see the T cells are really, in an angry state, that they can start the inflammatory response immediately after any minimal irritation, any minimal stimulation, either like micro trauma, even like eating might trigger it. Stress would increase the cytokines and start the inflammatory response. Hormonal changes, pregnancy, giving birth, period, anything might trigger the immune system and initiate an inflammatory reaction. Once there's an inflammatory reaction, there's a collection of the T cells. So T cells are the key player in the immune mediated condition here, and these inflammatory cells start to aggregate here, producing cytokines, activating other inflammatory cells, and as you can see, the epithelium is still there. So we call this a pre-ulcerative state. There's no ulceration yet, but there's inflammation in the area, there is redness, and the patient would feel it, that maybe there's tingling sensation or something is going on at the site of the ulcer. Once the inflammation is severe enough, this epithelium will break down and we'll have an exposed connective tissue. As you can see, there's a huge amount of T lymphocytes here in the connective tissue, and now we are in the ulcerative stage. And once things subsided, number of T cells would reduce, amount of inflammatory cytokines would reduce, healing would start to take place, and epithelialization would start to develop, very thin epithelial layer, and then the epithelium would start to build up. And this is in the third healing phase. Usually the pain reduces during the healing phase. So how can we manage the RAS ulcers? First, we need to confirm the diagnosis. We need to be sure that we are dealing with RAS, which means there is no underlying systemic conditions, there is no GI involvement, no skin mucocutaneous lesions. So we confirm this by doing proper history taking and by doing examination. And for a patient with recurrent oral ulcers, I tend always to do CBC, complete blood count, and not just this. You need to do folic acid or red cell folate. You need to do the B12. You need to do the ferritin to measure the level of the iron. So because sometimes the hemoglobin is normal, but the reserve of the iron is reduced, this would increase the frequency of ulcers in the patients. So once I confirm there is nothing, no hematinic deficiency, then I start treating the patient. And my treatment depends on several things, whether the patient has severe symptoms or just minimal symptoms, how frequent are the ulcers, and the location of the ulcers. So in simple aphthosis, when the lesions are so minimal, it occurs like every 3-4 months, the patient usually they do not even request a treatment. They can manage it on that day. But if there is extensive ulceration, very frequent, then usually patient would come to you asking or seeking treatment. The first thing you would try to educate the patient about the condition, try to figure out with the patient what might be the underlying triggers or factors. See if it is related to stress, related to hormonal changes, related to certain types of food. Some patients, eating preserved food would induce an ulcer. Eating certain types of food, like strawberries, for example, or chocolate, they tend to develop ulcers. So the key is to avoid these triggers. So this is the simplest thing. Then we go higher, like start to prescribe topical medication. I like topical therapy because it is very effective. It just goes straight to the point, straight to the ulcer where you need the medication most. Does not have any systemic side effects. It doesn't go to the circulation. So it's very effective. I always start with a topical medication. you can start with a simple medication like just analgesics, like benzocaine, for example, 20% benzocaine, which is available in the pharmacies, and apply it at the site of the ulcer. This would numb the areas, so the patient can use it at least prior to eating, so he can eat. Benzidamine, which is an anti-inflammatory, but we do not have it here in Jordan. Maybe you'll have it in your part of the world or in your country. Other topical therapies, covering agents, which actually the only thing it does is just cover the ulcer, forming a layer over the ulcer, so this would relieve the pain. We have here Aloclair, Orabase. We used to have it, not anymore unfortunately, but it might be available in your country. The Orabase, it is a substance that has the ability to stick to the oral mucosa and it does not wash out with the saliva. So this is very, helpful to the patient because it protects the ulcer. It forms like a bandage over the ulcer. The mainstay treatment is a steroid, and the main steroid I prescribe is dexamethasone, 0.5 milligram per 5 ml elixir medication. And this medication is actually used for children to swallow. I prescribe it as oral rinse. So the patient can use it QID, which means 4 times a day. Rinse and spit. And if the ulcers are so severe, I would ask the patient to rinse and swallow. Usually for any topical medication, it is effective when 2 conditions are met. The first thing, you need adequate time of the contact between the medication and the lesion. So the patient needs to rinse for like 2-3 minutes at least, and they need to set the watch to know that they have spent no less than 2 minutes, spreading the liquid in their mouth. The other thing is to keep the medication in the oral cavity, and this happens by stop eating or drinking for about half an hour after doing the rinse. So once the patient rinses his mouth, he should not eat or drink for half an hour to keep the medication inside their oral cavity. The best one, or the most important one, is the rinse before going to bed. So the patient should brush his teeth, rinse his mouth, and go to bed. They will have the effect during the night. So in the dexamethasone, I'll do that rinse and swallow, so they can have both the topical and the systemic effect, or rinse and spit in the minor cases. Of course, in the rinse and swallow, the patient should not stay in that for a long time, maybe like for the first week, and then he should rinse and spit. So this is the medication. There are, of course, other steroid preparation. I used to use prednisolone tablets, and the patient can dissolve it in water, and the same thing, just rinse and spit or rinse and swallow. If you have, or if the patient have one big ulcer that is really painful, the patient can use Lidex gel, which is fluocinolone. It is a very potent steroid, because the steroids difference in their potency or their strength. So fluocinolone gel is a really potent steroid, so we use it only twice a day, and I only use it if there is like a big ulcer that is really painful to the patient, so he can apply the gel over that ulcer. If the patient had an ulcer like in the throat, so he can use the inhalers that include the steroid inhalers, and use that puff or use it as 2 puffs or 3 puffs and in their mouth. They should not, of course, inhale it. They should not do that because they don't need it to their lungs. They need it to just topical application to the soft palate area, as it is hard to reach. Or maybe they can use the dexamethasone and gurgle. So this is the main medication I use. As I mentioned before, tetracyclines or minocyclines, they are good. They are antibiotics, but they have anti-inflammatory effects, and they are really effective, particularly in the herpetiform of ulcers. You just dissolve the cap, the the capsules, the powder of the capsules, you dissolve it in water and use it as a rinse. We've said that already. Systemic therapy, we go for systemic therapy only if the patient is not responding to a topical steroid. And here I would rather, for you as a general dental practitioner, to refer the patient to oral medicine specialist rather than trying to manage the patient yourself because of the side effects and complications of the steroid therapy. Just, for your information, what we usually tend to do is to prescribe a mid-roll dose pack, which is methylprednisolone tablets. They are given in like 6 tablets in the first day, then we go 5, 4, 3, 2, 1, and these tablets are spread along the day. This is very convenient for the patient, if they have the mid-roll dose pack. Here in Jordan, I don't think we have the mid-roll dose pack, but I just prescribed for them the methylprednisolone or prednisolone and state to them the way to take it. If the condition is so severe, I might start with burst therapy of steroid, starting with 20 or 30 milligram of steroid and tapering in 15 days time. Other options other than the steroids is using other immunomodulator like colchicine, thalidomide, azathioprine. These medications would help reduce the ulceration in case of complex aphthosis. So we use these only for complex aphthosis. These medications should not be prescribed by a general dental practitioner. So as I mentioned before, there are some conditions that might be presented clinically as RAS, but in fact they are not after stomatitis. They are caused by different systemic conditions. So you need to be vigilant of these underlying causes that might be presented as RAS. The first one, which we talked about, is nutritional deficiency. So you need to rule this out, because sometimes patients with anemia or iron deficiency or B12 deficiency, they will develop oral ulcers. They look exactly similar to RAS. But the difference is that those patients, once you correct the deficiency, once you provide them with iron tablets or B12, the ulcers would disappear. So they have, the underlying cause was nutritional deficiency, and they did not have that idiopathic RAS induced by exaggerated immune responses. It could be also related to GI disease like Crohn's disease or celiac disease. So once these conditions are corrected or treated, the ulcers would disappear. Cyclic neutropenia, which is a condition usually affect the children, that every, for example, month, the neutrophil number would drop, so the patient would develop fever, malaise, and ulcers, very similar to RAS. So, as we said, to diagnose RAS, the patient should not have any underlying cause. There should be no fever and malaise. And here in this cyclic neutropenia, if you noticed fever, malaise, if it affects the children and occur in a periodic or cycles, then you should think of cyclic neutropenia. HIV patient might develop ulcers very similar to RAS. There are different systemic conditions, including MAGIC, which is mouth and genital ulcers with inflamed cartilage. So the disease is what is presented here, or PFAPA, which is a periodic fever, aphthous ulcer, pharyngitis, and cervical adenitis. These are very rare conditions, inflammatory conditions, and the patient tends to develop ulcers in addition to other features. And Behçet's disease is another systemic condition. Drugs might induce ulcerations very similar to RAS, including NSAIDs like ibuprofen, Nicorandil, and methotrexate. So the patients taking these medications might develop oral ulcers. You can know that by asking if there's a coincidence between taking or starting this medication and the development of ulcer, and the ulcer would resolve by stop taking this medication. So we will concentrate or focus more on Behçet's disease only because it is a common condition in our part of the world. Behçet, or as we say in Arabic, Behjet, is the name of a dermatologist who recognized the condition of 3 patients that developed oral ulcer, genital ulcers, and uveitis, and they thought that this is a triad of these 3 conditions and give it the name Behçet's disease. Now, so this is an example of aphthous ulcer, so it can be any form of aphthous, minor or major or herpetiform. Hypopion uveitis, as you can see here, the conjunctiva, there's conjunctivitis, and the hypopion uveitis is the white blood cells here you see in the anterior chamber of the eye. So this is one feature of Behçet's disease. Now we know that Behçet's disease is not as simple as a triad. It can appear as anything. It can affect anybody or it can affect any part of the body because it is a condition of vasculitis, which means inflammation of the blood vessel. So the skin can be involved, the brain can be involved, lungs, GI, everything can be involved. And to make a diagnosis of Behçet's disease, the patient should have recurrent oral ulceration, in addition any 2 of these, either genital ulcers, eye lesions, skin lesions like erythema nodosum, pathogy test, which is a test they do by inserting the needle into the patient's skin. Normally this should do nothing for a normal individual, but for a patient with Behçet's disease, a pustule will form. So this indicates a positive pathogy test. So why I'm talking about this disease? Because first of all, as I said, it is very common in our area, and usually it affects young adults, like in their 3rd or 4th decade of life. Males and females are equally affected, but usually males, they have more severe form of the disease. The disease is present in this area along the ancient Silk Road. So in Japan, in the Far East, in Malaysia, these countries are highly affected with the condition, particularly Japan. And along the way, the ancient Silk Road, where the tradesmen used to bring goods and stuff from Turkey and get it to Japan and get the silk from Japan and to sell it in Turkey. So the tradesmen here, their way, we have a concentrate of cases of Behçet's disease. So Jordan lies here in the area, and it is one of the area that is affected or with high prevalence of the disease. In UK and USA, they consider this a rare condition, but not in our part of the world. What does that mean? This means that when you see a patient of aphthous ulcer, it is important to ask the patient if he has any eye lesions, any skin lesions, any genital ulcers, because if he's having anything or any of these symptoms, you need to refer the patient to a rheumatologist. Usually they take care of the patient. How the patient is treated, now he's under the care of the rheumatologist. If his eyes are involved, the ophthalmologist will be involved in the treatment. If the skin is involved, a dermatologist would be involved. So it depends on where the disease is active. So this is why we call it a multidisciplinary approach, because usually the patient is under care of several physicians from different specialties. And the main treatment of that disease is a steroid therapy, as a systemic steroid therapy. And usually the patient will start receiving other medications like azathioprine, colchicine, thalidomide, or maybe the new biologic treatments to reduce the inflammation or the vasculitis. What is our role? Your role as a dentist, as a general dental practitioner, is to recognize the condition, to know that this is not a recurrent aphthous stomatitis, the simple form of idiopathic recurrent aphthous. This is part of a systemic condition. And we as oral medicine specialists, we tend to be part of that multidisciplinary team. Because usually the oral ulcers are the first ones to appear and the last ones to disappear. So we tend to manage the patient with a local or topical treatment. Instead of increasing the dose of systemic medications, we tend to treat the ulcers locally. So the oral medicine specialist is usually part of the multidisciplinary team treating the patient. So to conclude our lecture today, we talked about oral ulcerations, the 3 keys of success to make a diagnosis: proper history, proper examination, and investigations when needed. I talked to you about recurrent after stomatitis in details, their etiology and treatment, and some of the RAS-like ulcers or conditions that develop RAS-like ulcers, and focused more on Behçet's disease. This flow chart I thought would be useful for you to make a diagnosis, to check if there is pre-existing systemic disease or if the patient is taking any medication. The ulcers might be related to the medication, or might be oral manifestations of the underlying disease. If the patient is healthy, there's nothing you need to check whether the ulcer starts as a vesicle or bulla. This indicates, or if it arises as an ulcer. If it arises, which means arises de novo, means like it started as an ulcer. And if it started as an ulcer, we need to check whether it is a persistent or chronic or recurrent. If it is recurrent, you need to figure out whether it is a recurrent after stomatitis. There is no underlying systemic causes, and then we treat it as we discussed earlier. If it is not an after stomatitis, maybe there is an underlying, it's a RAS-like, there's underlying condition, so you refer either to GI specialist if you suspected GI, or dermatologist if you suspected mucocutaneous. If it is a persistent ulcer, this might be related to a local cause, like chronic traumatic ulcer. We remove it. If it resolves, that's it. If not, we take a biopsy. If there is no local cause, and if it is persistent, if it is multiple, then we need to take a biopsy. Usually it might be any of the chronic mucocutaneous diseases or vesiculobullous diseases. If the ulcer was preceded by a vesicle or bulla, and this bulla ruptured, then an ulcer appear after the rupture of the vesicle or bulla, then it might be it might be a viral infection if there is a fever or malaise associated. If there is no fever or malaise and it has been there for a while, I would think of more of vesiculobullous disease. So this chart puts together the possibilities that we discussed in this lecture. Oral ulcerations is very important, lecture, because it introduces you to the coming lectures in mucocutaneous conditions and vesiculobullous GI disease. So you need to know these topics and be more confident in dealing with such patients. That's all what I want to talk to you about today, and see you next time, inshallah. Assalamu alaikum.